Welcome to our Just Talk, Talk Just panel discussion, The Black Tax in Healthcare, How Race Impacts Healthcare Outcomes. Sponsored by Union Presbyterian Seminary's Center for Social Justice and Reconciliation and the Katie Geneva Cannon Center for Womanist Leadership. The conversation taking place today is similar to the dialogue that happens in our academic classrooms. Union would love to be in touch with you about opportunities to further your theological education. Attend a virtual open house by contacting our admissions office at admissions@upsem.edu. Our panelists are Reverend Dr. Shakira Sanchez Collins, primary care physician for the Osher Center for Integrative Medicine at Northwestern Medicine, and Associate Pastor for St. James AME Church in Chicago. And Dr. Augustus Parker, Medical Director for Women's Urgent Care Centers, Facilitator for Diversity, Inclusion, and Health Equity, and Community Ambassador at Novant Health. Our host and moderator is Dr. Rodney Sadler, Associate Professor of Bible and Director of the Center for Social Justice and Reconciliation at Union Presbyterian Seminary. Dr. Sadler, the floor is yours.
Thank you so very much, Mike. It's great to be with you today as we come together to talk about what's going on with African Americans in this nation and their healthcare. Why is it that it seems as though African Americans seem to suffer much more from health maladies than their white counterparts? What's going on with treatment? Is there something about the way that African Americans are treated that leads to these different results? We have a lot of questions to wrestle with today as we take on this new edition of Just Talk, Talk Just. Just Talk, Talk Just is a partnership between Union Presbyterian Seminary, the Katie Geneva Cannon Center for Womanist Leadership, and the Center for Social Justice and Reconciliation. We, in the aftermath of the George Floyd uprising, said that we've got to do something to help the larger community understand what's going on with race in America, what's going on with African Americans in all sorts of spheres, healthcare, education. How do we wrestle with crucial issues like critical race theory? How do we answer some of these questions? And how do we do it in such a way as to take seriously the theological and biblical dimensions of these concerns? That's sort of what we're going to do tonight as well. As we have a wonderful conversation, I'm incredibly excited tonight to welcome the Reverend Dr. Shakira Sanchez Collins, and also the Reverend, I'm going to give you a Reverend, Dr. Gus Parker, I should say Professor Dr. Gus Parker, as we come together. Reverend Dr. Shakira Sanchez Collins is a health and wellness expert, physician, minister, and preacher. Poised to make a difference in both the ecclesiastical and medical field, she has demonstrated her commitment to helping families and communities live well spiritually, physically, and mentally through her work in the church, community, and academy. I think, Gus, the last time we had a conversation, we were talking about a person just like her as what we needed for the African American community. Dr. Sanchez Collins is a graduate of Yale University, where she obtained a Bachelor of Arts degree in Religious Studies and a Master of Divinity degree. Furthering her knowledge, she has studied theology at the University of Cambridge in England, womanist theology in Brazil, and sacred music in Germany. She's hit about every continent that we can think about to do some studying on. She currently holds a doctorate of medicine from the great Duke University. I'm biased here, so that'll come out. She currently practices internal medicine as a physician and serves as the associate pastor of St. James AME Church in Chicago, Illinois. And she's married to the Reverend Craig Robinson, who is the pastor at St. James Church. We're also joined today by Dr. Augustus Garland Parker III, or Dr. Gus, as I like to call him. Dr. Gus is the medical director at Novant Health Women's Urgent Care Services and Community Engagement Ambassador. He is a board-certified practicing physician in the field of obstetrics and gynecology. Dr. Parker is an inventor holding patents on medical devices and tools used in the practice today. He is a member of Friendship Missionary Baptist Church in Charlotte, where he lectures on numerous topics related to healthcare. He's a man of faith, and that faith comes into the work that he does. He's even made a film debut in a comedy movie playing a doctor. Dr. Parker has earned his BA degree in biology from Kent State University in 1977. He then attended the University of Cincinnati and received his medical degree in 1981. Dr. Parker also is an author, having recently completed his book, Mining Diamonds, which I'm pleased to say is on my bookshelf here as well. He's married to Cheryl Gibbs Parker, and they have 3 children. And I want you to listen to this. Dr. Augustus Parker IV, Dr. Jason Parker, and Dr. Krista Parker. All of his children have gone into the field of medicine and continued this tradition. One of the things you'll probably talk about tonight is the need for more African-American physicians to help out with our community health needs. He is also a newly appointed faculty member at UNC's Chapel Hills branch campus at the Novant School of Medicine here in Charlotte, North Carolina. Dr. Sanchez Collins, Dr. Parker, I'd like to welcome you both to our conversation tonight.
Thank you.
So let's just start off with a softball kind of question here. We've heard about these healthcare disparities that exist between Black and white patients. Many people might be pondering, maybe Black people just aren't as hardy or as vibrant as their white counterparts. Is the differences, the disparities that we see in health and life expectancy, are they due to biology, to genetics, or to other environmental factors? Or is it something else that's involved there? I'd love to start off with you. How about Dr. Sanchez Collins? What do you think about that?
Yeah, the cause of the disparities between Black Americans and white Americans in the U.S. is definitely caused by a multitude of different factors. And I'm sure that Dr. Parker will probably also touch on this later too. So I think one of the most obvious differences is the higher rate of poverty. And so when we think about all of the, whether that is access to having great grocery stores within a neighborhood, whether it is access to living in a neighborhood that has a lot of green space. Green spaces, encourage walking around and being outside, which is also important for health. Also, just being able to have health insurance. There was a even larger gap before the ACA between Black Americans and white Americans in regards to healthcare insurance access. Even though that has somewhat improved, that gap still exists. And then a more complex concept, even when we account for all those different factors, there are some influences of and impacts of systemic racism that does have different types of impacts on the health outcomes for Black Americans.
Thank you. Thank you so much for that. And that's a nice, interesting, nice introductory salvo, because I think many people are questioning the issue of race and the way that it impacts people's lives. And maybe there is a genetic inferiority or something associated with Black people. But please, would you say more about this, Dr. Parker?
Yes, thank you, Rodney, and thank you, Doctor. One of the analogies that I really like is that the imagery of, if you see a pond and you see a fish floating dead on the water, then you look at that scene and you say something's wrong with that fish. But if you look at that same pond and you see hundreds of fish floating on the pond dead, you say something's wrong with that pond. Mm-hmm. And that analogy I love, because it says that the pond that we live in, for a majority of us as people of color in the brown and Black community, has been poisoned to some extent. And so that figures into some of the things that Doctor alluded to, the social determinants of health. Clean water. Oftentimes, because of historical redlining, we're codified in these neighborhoods where we're living next to factories, polluted air, runoff from chemicals in our groundwater. and in our water. The doctor mentioned food deserts, poor educational resources, and all those things certainly figure into that zip code matters. Not only that, when you figure for many of those things, as was mentioned, oftentimes we've historically learned. We used to think that part of our poor outcomes was a lack of access. Well, we've matured and understand that there's something else going on. I think the social injustice that we saw in our country only revealed what was already there, which is there's systemic racism, not only in the criminal justice system, but also in healthcare. There's also this concept that we'll talk more about, that a lifetime of stress, being Black in America, whether you call it weathering, whether you call it the intersectionality of life experiences, whether you call it allostatic load, there are a lot of work that's being done in those areas that say that those impact you from cradle to grave and results in things like maybe your immune system doesn't respond as well as it should, or that these stresses trigger other diseases with high cortisol levels and high blood pressure. So there are a number of factors where racism may play an underlying tone. And so we say it's not necessarily race, but maybe racism.
Thank you so much for taking us in this direction. This is definitely one of the questions I wanted to explore a bit further. I remember back when I was in the 80s, when I was in college at Howard University, Dr. Jules Harrell and Dr. A. Wade Boykin in the psychology department were doing intensive studies on the impact of racism on things like hypertension and other factors about health. And I thought it was fascinating to think that the stresses of being Black in this society can contribute to poorer health outcomes, and not just poorer health outcomes, but to producing poorer health in the short term as well. I'd love for you to talk a little bit more about this, Dr. Sanchez Collins. I think you're muted.
Speaking more about the allostatic load. So basically that experience of racism, what they call, another way they talk about it is like perceived racism, just because it's how you felt. If you felt that you were in a racist moment, that actually causes a stress response in the body, like the fight or flight response. And so that persistence of stress over time, like Dr. Park was talking about, that weathering over time has been thought to just add up. And at some points, there were some studies that have looked at how there might actually be just over time microbiological damage on the body, and so that itself is what leads to having higher episodes of diabetes, outcomes to cancer, other chronic diseases that can be more likely to happen in Black Americans. So literally, racism itself is hazardous to the health of Black people. And so, we have to be aware of that, because versus it being seen as there's something pathologically wrong with Black Americans, instead of looking at what is the pathology of the environment in which a lot of Black Americans are living in. And I think that, by recognizing the importance of the racial stress, that's how we'll see the disparities between Black maternal death rates compared to those of white Americans, even when you are comparing women who have college degrees compared to white women who only have a high school education, and how we still see a disparity when we have accounted for all of those other determinants of health.
No,
And Reverend Sadler, if
certainly.
I may,
Please.
the brunt of all those impacts are sometimes borne out in implicit racial bias. Someone reminded me, it's not just implicit, it's explicit. And as we I've got to say this, a dear friend and my neighbor prior to moving down here is Congresswoman Joyce Beatty. And you may have seen in the news today where she was verbally assaulted and pushed by a member of Congress who just issued an apology, and he not only he used vulgar language in how he responded to her simply because she asked in boarding the train, would he mind putting on a mask? Those microaggressions, micro insults, micro assaults throughout a course of your life result in some of these things that we have talked about that physiologically impact how you deal with those kind of stressors.
It's frightening to hear that the many small instances have a cumulative effect on people's long-term health. And we don't think about this in relationship to the way that African Americans are treated in general, that living in a racialized society has immediate negative impacts on all aspects of your life. I think this is probably something that we have to look at more with the Reimagining America project as we go forward. I've often heard reports about the amount of time that physicians spend with their patients differing between whether or not the patients are white or whether or not they're Black. That doctors have routinely spent less time with their African American patients, less time probing about issues. To what extent is this as well a factor in sort of disparate health outcomes? Start with you, Dr. Parker, this time.
Yes. Well, there are a lot of studies that talk about how patients are treated differently based on race, based on sexual orientation, and other differing abilities. And a lot of those studies reflect the fact that there are Black patients that are less referred for invasive procedures, less referred for medical regimens, be it chemotherapy, less referred for specialists. And a lot of their concerns are thought to be unfounded when patients are expressing things. They're not listened to. And a lot of this, again, plays into that implicit and explicit racial bias that sometimes providers have toward people of color. And I think those statistics are borne out in some of our benchmarks that we use. For example, infant mortality, the number of deaths per thousand, how many children survive the first year of life. We have an abysmal record of 2.5 to 3 times greater than our white counterparts. Now, that's just for a child surviving. If we can't take care of our most vulnerable population, what does it say about the rest of the adult population? That is a national, a state, local, worldwide statistic that's used as a benchmark. That's a mere reflection of the overall health of the community. And North Carolina ranks anywhere from 30th to 40th worst in the country relative to infant mortality, relative to maternal mortality. We have Black women that are dying at 2 to 3 times the rate as our white counterparts during childbirth that are considered preventable deaths. So a lot of that you've heard about Black women raising concerns about knowing that they don't feel right in their body and their concerns being dismissed or felt to be unfounded, only subsequently to succumb to devastating disease, blood loss, and things that contribute to those maternal mortality statistics. So there are many, many examples. You know, African-American men are living 5 to 12 years less than their white counterparts. And I can go on and on and on about those things, but those are certainly benchmark things that we have to pay attention to and figure out a way to close the gap in those health disparities.
Thank you. Thank you so much for those responses, those sobering responses, I should say. Please, Dr. Sanchez Collins.
Yeah, no, to add to that, even in this pandemic, oftentimes, you know, when we think about the practice of medicine, there is the objective parts, but there's also the subjective part of medicine. You know, maybe a way the patient winces in a certain way makes you lean more in this direction in terms of like if they're having certain levels of pain, like it might make you lean more towards ordering a certain test versus another test. And there's a lot of subjectivity, I think, is what creates that space for the disparities and where the bias is able to come in. Even in this pandemic, right now, the main treatment plans there's the monoclonal antibodies, and there are also remdesivir, dexamethasone, other medications. And even over the course of the last year, there has been a disparity in how that Black Americans have been less likely, particularly more so in the outpatient setting than the inpatient setting. But in the outpatient setting, they've been less likely to always get the monoclonal antibodies, less likely to get, other treatments that have been out there. And so one of the things I think is also challenges, because some of that is subjective, but also some of that is, based off of what neighborhood you might live in. Does that healthcare system have access to those treatments? My hospital system just started doing the antiviral pills for COVID-19 pandemic. And so there's criteria. There's criteria that's supposed to be for those treatments, but you just never know in terms of when there's a limited supply, who winds up being the ones that are more likely to go without than others. So that's definitely something that, we could talk more about this later, just, being aware of that, I think also can inform people when they're in their visits, and just make sure that they are getting what is the most current treatment.
Thank you. Thank you so much. I appreciate that. And we have talked about certain environmental factors in general, racism as a factor from the larger environment that impacts people's lives. We've talked about other issues. I'd love to hear about the way that the physical environment also influences this. I've heard that African Americans are 75% live within 30 miles of a coal ash power plant, which contributes to considerably high instances of asthma and pulmonary disease. Also, that there's far too often African Americans, I heard this term for the first time last night, not just live in what we call food deserts, but a food apartheid system that does not provide fresh food there. What is the impact of this on disparate health outcomes? Start with you, Dr. Parker.
Well, I kind of mentioned that that pond that might be next to a factory and where you live, and the runoff of water, groundwater, and how there might be cancer-causing chemicals that your kids are outdoors playing in. When you mentioned about food deserts and food apartheid, imagine, if you will, that there aren't fresh fruits and vegetables, and some of this is rooted in education. We've got to better educate ourselves and our people in terms of food selection and how to eat. But you have to have some place to shop for those things. You also have to have the knowledge and experience to how to cook those things and different ways to prepare meals. So, we can get into solutions, in terms of food gardens and in communities. But if you talk about those physical things, this gives rise to things like childhood obesity, because there are only fast food liquor stores in our neighborhoods that don't supply fresh fruits, produce, and good quality foods. So high carbs and sugary drinks and all those sorts of things, and alcohol can certainly start off from the cradle to the grave. And if you start out with childhood obesity and those sorts of problems, which is in epidemic proportions in our communities, that spills over later in life to hypertensive disorders, heart attack and stroke, and those sorts of things. So those are just two examples of those environmental physical things that you just alluded to.
Thank you so much. Dr. Shakira, Dr. Sanchez Collins?
Another aspect of environment will be proximity to quality healthcare. During this pandemic, in certain Black neighborhoods, there is a community hospital, and often that community hospital does not have the same resources as the hospitals that are located in the downtown. That if anybody knows anything about Chicago, there's a major disparities between the north side and the south side, and so the resources that health centers have in the south are definitely not at the same level as those that primarily serve the north side. And so even in this current situation where there have been surges with the COVID-19 pandemic, healthcare has suffered at places that were unable to handle both the COVID-19 surge and also dealing with the everyday surgeries and care that needs to happen in order to keep people from dying of other things. And so I think that that is one of the major environmental issues, and that just within the last few years we have lost a hospital that was serving a lot of the Hyde Park area. So we have actually lost resources and access, and so that means that people have to go further away, which becomes another barrier to getting the health care that they need.
Thank you. Thank you so much for that. As we wrestle, I want to return to a question or that you've commented on a bit already. Has to do with maternal mortality and infant mortality. We hear that these are significant concerns. You've mentioned 2 to 3 times the death rate for African American mothers. How do we begin to turn the tide in this regard? What are the things that we might do best practices that could help us begin to cause a shift in some of these disparities? We'll start with you, Dr. Parker.
Yeah, well, I think of 2 things, and one is that you have to have a patient advocate, and some of the gains that have been made relative to maternal mortality and those sorts of issues, and I think this would be pervasive throughout all fields of medicine. And that is the use of things like doulas, for example. There have been programs where doulas have been engaged with a pregnant woman during her pregnancy, certainly during labor and delivery and postpartum, and also initially in the infant child care. And those studies have proven that when you have an advocate, a doula, someone that's going to support you through those challenges, and even we alluded to transportation issues in terms of accessing healthcare. So the more people that you have in your village to support you and to be a voice and an advocate and demand the attention of the healthcare professionals, the better off we'll be. And that, we need to have more community health workers that are being paid, that live in neighborhoods, that are being paid a living wage, not a minimum wage, but a living wage, and a pathway to additional education. We need to train those community health workers. They know their community, they know their constituents, and they're trusted by their constituents. And if we can bridge the gap by using people like that, they can help us identify at-risk populations, teenage girls that need birth control, mothers that have potentially drug addiction, and be a patient navigator to get them into the system. The other thing that is a spinoff of that, and you alluded to it, is that we have to engage more of our young men and women to engage in the healthcare system.
Amen.
I'm on a crusade to get more young African-American men and women in the healthcare. And I'm not just talking about being a doctor. I'm talking about we need more African-American nurses, counselors, mental health providers, administrators. If you're not at the table, you may be on the menu. So we need to get more people involved at the hospital level, the boardroom, and that sort of thing, where decisions are made. As we've transitioned in medicine, one of the poor things that has happened is that family practitioners used to go to the hospital and make rounds. And because they were going to the hospitals, they were involved in the body politic with what was going on. And they were on hospital committees and sanctioning committees and review boards and took leadership positions within the hospital. But now your primary care doctor doesn't go to the hospital. They refer you to a hospitalist like Dr. Sanchez here at Collins. And those are good things. But if you don't have that relationship where you're seeing a provider that may reflect more of your life's experiences, because we see them and feel more comfortable relating to them, then we're going to continue to suffer some of these disparities. There's something to be said for trust, and we could do a whole talk on the mistrust that exists historically, past, current, and present.
Yes.
Present and current. So that's another thing. But those two things, patient advocates, use of things like doulas, patient navigators, and then real quickly, the expansion of Medicaid, for example, in the state of North Carolina.
Yeah.
I used to be a senior medical director for a managed care plan. Those managed care plans with expansion were able to provide transportation benefits and other incentives that got people care that they needed, when they needed, and how they needed. But I'll pause there.
Thank you so much for quite a thorough answer. Please, Dr. Sanchez Collins.
I think when it comes to the maternal question, I think that was a very great answer.
Amazing. It was amazing. Yeah.
Thank you.
Yeah. Yeah. So, well, then, why don't we sort of follow up with that general trajectory that we just started to work with here. I've been impressed with the fact that both of you are active in your church, and I have a feeling that your church bears the benefit of your healthcare specialty. What do you think is the role? I mean, we live in a faith community in the Christian world that is in part built upon the miracles of healing by Elijah and Elisha, by Jesus's miracle work. What's the role of the church in helping to shift the way that community health is, the way that the community is aware of their health concerns and actively dealing with health issues?
Yeah, I would say it reminds me of this book by Dr. Emily Towns. She's now the dean of Vanderbilt Divinity School. She's called "Breaking the Fine Reign of Death: African American Health Issues and a Womanist Ethic of Care." It's a great book. I love it. It's on my bookshelf.
Put that in the chat. Yes. Thank you.
And so the whole point of the premise of the book is first there comes the lament, and then second there comes the response. Yes. And so the lament is basically, part of what we are doing in the part one of this panel is being able to call out the issues, call out what actually is wrong, so that given that they are identified, then figuring out actual responses to them. And I think that the Black church stands in a great position to do that, just because historically we've always have been in a place where we've addressed community concerns. Even back in the day with the yellow fever epidemic in like the 18th century, the AME Church, the founders of the AME Church actually were nurses. The first bishop of the AME Church was a nurse dealing with patients in the yellow fever epidemic. So I think that we are very well positioned to make that response. And so I think a couple of things that the church is in position to do is to make sure that there is relevant messaging, and paying attention to what's actually going on people's lives. And in two ways, I think actually the church should be a balm in Gilead. So addressing the stress, addressing the anxiety, addressing the depression, addressing the stress of Black people, which since that has an effect on the outcomes of Black people, making sure that we're addressing mental health concerns, that we're creating spaces that are warm, spaces that people want to be around, spaces where they feel supported. That itself has just a direct connection to the overall holistic care of Black lives. Another way of providing relevant messaging is bringing awareness. I think that in churches that do have health professionals in them, often benefit to able to have people to keep them informed. Just me telling you about the new COVID medications and having people letting this information be given, so that when people are getting sick, they're knowing what to ask for. The other obvious way that a lot of churches were helpful this year was, providing testing, providing vaccinations, basically taking advantage of the fact that location-wise, as a geographical point of access, we are able to supplement what is typically done in the healthcare settings. And so I remember there was a program called Sister Talk that I used to work with back when I was in medical school. And it was a program where it was an obesity management program. It was a lifestyle modification program called Sister Talk. And we worked with churches in the New York City, AME churches, Roman Catholic, Episcopalian, and created a curriculum that was able to combine the biblical lessons, but also teaching upon like diet, teaching upon talking around emotional eating, different things like that. So there are many opportunities to really utilize the cross section of culture, beliefs that can help put the message in a way that's understandable, a way that is more easily accessible. And I think that the church is a great place to do those things.
Thank you. Thank you. I love that. And the fact that the church is intentionally using its pedagogical background to reach the community and inform them. Dr. Parker?
Oh, I don't have much to add to that. I'll say that, generally speaking, and we had this conversation recently, that there's been somewhat of a backlash against medical science and in recent years. I don't know if that's more access to the internet where people are finding information and misinformation. But when you talk about trusted, iconic leadership in a community, it's not Dr. Parker. It's usually our Black pastors at the church. But I will say that I'm so proud of my church, Friendship Missionary Baptist Church, in the heart of the Black community, where the pastor has been on the forefront of giving not only space for vaccine for viral testing and vaccine administration, but also has given me and his men's group in the church a platform. I'm proud to say that I'm the city coordinator for the National African American Wellness Project.
Yeah,
and we host that festival and event there with a 5K run walk awareness campaign where we have entertainment, and our sole mission is to raise awareness about these health disparities and get men moving, know their numbers, and get connected with a healthcare professional. And that it's a door-to-door guerrilla marketing campaign where we really go about trying to assess the community with providers in a different way. And we try and engage all physicians of color to participate in those efforts.
Mm-hmm.
And so again, I'm proud of the fact that the pastor gets up every Sunday and says, "Wear your mask," and gets up and a lot of times there are some pastors and in the religious community, I'm going to be a little critical here,
Mm-hmm.
that toe the line when it comes to politics. They don't want to seem partisan at all. And that goes for not only politics, but medical issues and as it interfaces with religion. God gives us a brain of discernment, and it also gives us tools. God doesn't say, "Believe in me and, you can walk across a busy highway and I'll protect you." He says, "No, you have a brain to discern, and there are tools to help you get across that highway, be it a traffic light, a traffic cop, and other tools." So hopefully as physicians, we're tools to further that message and be of great care to our communities.
Thank you both for such thorough answers on that. I have a question that was raised by Dr. Parker, but your own notion of distrust. You talk about distrust, and I'm thinking about the Tuskegee syphilis experiments. I'm thinking about the current backlash against COVID. We can't trust our doctors to provide us something. We're afraid that they're co-opted by a big pharma. We're afraid that they are in league with I don't know how what's his name? Fauci. His name has become a bad name in delivering healthcare. But we hear this over and over again in the community. How do we begin to not just build trust, but recognize what the lack of trust does to hurt African American health? I'll start with you, Dr. Parker, on that.
Well, I think one of the things that I referenced was trusted, iconic leadership in our communities.
Mm-hmm.
And it may not be a healthcare professional, but as I said, we lost a giant here in North Carolina, Reverend Sadler. I'm sure you're aware of our dear friend and colleague that we lost.
Yeah. Ophelia Garman Brown's loss
Yes.
was monumental.
Yeah, if you don't know about Ophelia Garman Brown, she
Mhm.
was a giant in medicine and religion. And so I always use her when I use that term, trusted, iconic leadership,
Yes.
because she would reach people that I could never reach. I'm fairly new to the Charlotte community, but she has a history here in the state of North Carolina. She has a platform religiously. She has a platform medically. And so we have to lean on those leaders in the community that are trusted, iconic leadership to connect us with the healthcare system.
Thank you. But it often seems that we need to be able to trust our doctors too. How do we? And I mean, maybe there's an alliance that's needed. When you were talking about the run for African American men and their health, I want to put the Charlotte Clergy Coalition for Justice at your disposal to help you with that. But how do we begin to sort of nurture that trust again with the larger Black community? Dr. Sanchez Collins?
I think one of the ways would be we've been doing some talks about doing more health awareness education in our men's ministry for that reason. I think equipping people with kind of knowing how to navigate these systems. I think a lot of the things that sometimes makes things nerve-wracking and concern for trust is when you don't know how to navigate certain systems. And I think it's unfortunate that in our country you have to know how to navigate our health system to get the most out of it. And I think by equipping people to know, like, okay, what should I be asking for, based off of my age, what tests should be ordered, and just kind of knowing that, like, if they have a concern that they feel like was not acknowledged, knowing that it's okay to find a different provider if the first one did not actually hear you out. I think that often people, unfortunately, and for good reason, give up. But I think that often it just might be the provider that needs to be changed for you to be listened to. So that would kind of definitely be my approach in terms of just give it a more trusty relationship. But I think also on the flip side, they are starting to do even more implicit bias trainings in hospitals and healthcare settings, and so it's both sides. One side needs to get better at not at being aware of bias that is negatively impacting the health outcomes of Black Americans, while also Black Americans could be more informed as this transition happens over time, how to still navigate the system.
Thank you.
And if I may add to that,
Please.
I think I'm an activist, and I think we need to ask more of ourselves as healthcare professionals. I think, you talk about community policing, and you talk about getting out in the community and those officers walking the beat and getting to know their constituents, as opposed to being behind a bulletproof vest and in a bulletproof car and driving through the neighborhood. So I think we need to ask more of ourselves in terms of more community healthcare. I think while we all, and unfortunately more and more providers that come out of the medical pipeline are becoming employed physicians by big companies. And so there's some limitations on what you can and can't do. But I think the good systems will provide a vehicle for you to go into the community and do some of this work and get paid for it. We've always, as Black physicians, have been relegated to, you go take care of your community and get the low reimbursement, the highest risk patients, and do that. And it's not feasible to think that all of us are going to be able to take care of all and eliminate all the problems of the Black community. But I think if systemically, we may be able to figure out a way that we can give back to our communities and get paid equally for it. and at the same time allow people to touch, hear us, and more importantly, that we hear them.
Amen. Thank you for that. And I love the way you ended, that we hear them. Let's center the population. Let's let their voices be heard. Let their concerns be raised. So often we miss people in these conversations. A couple questions from one of our audience members today, Mark Davis. I want to try to combine them. In what ways do we need to strengthen public health infrastructure to make a difference? And is there money that comes from this new infrastructure bill that could be used to affect change in minority community health?
Well, I'll start by saying, when you talk about infrastructure, there's two things that come to mind. There's the physical, and then there's the psychological. Physically, I think there are more institutions that are recognizing that we need to go into the communities and build healthcare centers where the need is greatest. And we talk about those zip codes. Mm-hmm. I'm proud to say we have a relationship here in North Carolina with the Michael Jordan Health Clinics centers that we are putting in place. And so that's some of the physical infrastructure things that hospital systems can do to take care where it's needed the most. When you talk about the psychological, and Dr. Sanchez Collins touched on this, mm-hmm. and that is, our campus here in Charlotte for medical education has a focus of health equity. So we're starting to try and figure out ways to embed that in the entire medical education process, mm-hmm. Implicit racial bias and how you relate to patients in a professional way. Needless to say that we need to start even at the medical school level. One of the things that I was involved in, and one of my colleagues, Dr. Quinn Capers at The Ohio State University, was everybody that was on the admissions committee had to go through implicit racial bias training. Hmm. So you can't pick people to come into the medical profession if you don't have the sensitivities to understand your own limitations and how you perceive those candidates. So those are some of the things that are beginning to be done in a physical way with physical infrastructure, as well as psychologically how we need to train our next generation of healthcare professionals and how to relate to patients and listen to patients and hear them.
Thank you. I appreciate you taking infrastructure in that broader sense, both physical and how does the sort of mental health infrastructure play a role in this as well. Dr. Sanchez Collins?
Yeah, I think also will help if there's a better, strong relationship with the medical community versus the public health community. I think that over the last, think about the history of medicine in the U.S., there's been a wider gap between those two areas of health. And, mm-hmm. and often I think that, our country right now is at a crossroads and figuring out how do we better fund public health, but also how do we keep people in the field of public health. Over the course of these last 2 years, in various states all over, a lot of public health people have quit. This has been a very difficult time. It's public health is definitely a difficult job to do, because often if your public health work is successful, that means that something bad doesn't necessarily happen. But when something bad doesn't happen, it's not as easy to say, well, we did this and this didn't happen, which means that we did a good job. So it's sometimes because it's so, if you're trying to prevent something, it can be hard to say that this is why this is important. So I think just as a society, we would definitely have to invest more money in order to have a more robust infrastructure in public health.
Mm-hmm. Thank you. Thank you for that. I want to lift up this concern from Joanne Nelson. She asked this question: how can we as individuals be better advocates for our own healthcare? We've heard about what the system can do. What can individuals do to become their own advocates as they look for improving their own healthcare in communities? Dr. Parker.
Well, I talked about patient advocates.
Mhm.
Oftentimes, our patients don't have the knowledge about disease processes and what's going on to be able to discern what they need. You know,
Mhm.
it's kind of like you don't know what you don't know. And so I think you have to have an advocate. I can tell you countless stories of myself, my relatives that have engaged the healthcare system, and had it not been for the fact that they had an advocate such as myself,
Mhm.
the horrible experience that they might have engaged in. I think you need to make sure that your voice is heard, demand that your voice is heard. And if you're not being listened to, then it's kind of like if you're the smartest one in your group, you need to find a new group. And if you're in a healthcare setting where you're not being heard, you need to find a new doctor.
Mhm.
Um, the other thing is, I do have some bias relative to the fact that we have outstanding Black and brown healthcare professionals, and I think you ought to actively seek them out, because you will have a different experiential experience
Yes.
in healthcare when you engage one of them. We have, not everybody passed with honors in medical school, so there are good doctors and bad doctors. So uh, color isn't the defining characteristic of a good doctor, and
Mhm.
nor is it a bad characteristic. But I think there are adequately in numbers great healthcare professionals that reflect the communities that they serve, and I would advise you to seek them out. And if they aren't a good fit for you, keep looking, but you need to advocate for yourself, uh, particularly.
Thank you. Dr. Sanchez Collins?
Yeah, to add to that, particularly in a lot of healthcare systems, there actually are patient advocate departments. The reason why I bring that up is because sometimes it just happens. If there is a miscommunication, or feeling like you're not being heard, or feeling like something's not being done a certain way, often is good to reach out to the patient
Mhm.
advocate office, because they will then communicate and be the middle person to make sure that what the doctor is saying makes sense, and make sure that the needs that are there are being addressed in the best way that they can be. But also, just like Dr. Parker say, I think that people should be able to get second opinions. Like, that's a real thing. If one doctor says something, you get a second or a third opinion, and that's totally fine. And then I think that you can you know make a
Mhm.
educated conclusion based off of having at least a few different people giving you different options for treatment.
Thank you. Thank you so much. As I'm listening to you all talk, I'm imagining it might be interesting to have a forum where we go over some diseases that are prevalent in the community and just sort of help people learn what kinds of questions should you ask if you have hypertension? What kinds of things should you do before you just say, okay, I'll take this prescription? What kinds of things do you investigate before you do that? Diabetes. What do I do about my diabetes? I wonder if it might be interesting to have a forum at some point in time where we do some basic education for people so that they can begin to be better advocates for themselves if they don't have a Dr. Gus Parker as their cousin, brother, son-in-law. So yeah, I wonder if it might be interesting to do that kind of training at some point.
Reverend Sadler, there's a concept called ethnopharmacology,
Mhm.
and relative to do certain medications work differently in different populations. And there are some physicians that are very knowledgeable about some of these things. I think, there's also, we have to get back to a holistic approach in medicine, and get away from this notion that we're a society that's a society of pill poppers, and that and holistic approach, mind, body, soul, nutrition, all those sorts of things, alternative medicine.
Mhm.
Um, those are all great things. And I certainly went to a traditional medical school,
Mhm.
So some of my education relative to those things, alternative medicine, came outside of medical school and outside of residency. So I think those have proven to be non-Western medical approaches to disease and illness. So I think the more we can educate ourselves as professionals, as patients, and look at alternatives, you have to find what best fits for you. And so I would encourage people to look at those alternative things. You know, people say sometimes they're apologetic about, well, I read this on the internet, and I say, no, I'm fine with you going on the internet. It can be a great source of information. However, it can also be a great source of misinformation. So do your research and come back to me with questions, and I'll be happy to address them as best I can.
Amen. Thank you. I so appreciate you as a medical doctor saying, let's be open to what things might work for you, even if it stands outside of the bounds of traditional Western medicine. Thank you for that. I want to say right now, I know we're coming to the end of our hour together, but I'd love to ask you, as we close out our conversation, you've got the church listening to you tonight, the Black church, white church. What is as we think about this issue of the disparities that exist in Black health, what is your word to the church? What do you say to us as faith leaders that we might be more attentive to this issue and work better to alleviate these disparities? We'll start with you, Dr. Sanchez Collins.
Yeah, so I think the church should focus both on the big and the small. With the big is, a lot of these health concerns and issues are due to systemic issues in access to food, decent housing, environmental justice issues. So that is the big. So making sure that we are able to, get really advocate for legislation, advocate for community officials to do the big things that make public health impact. And I think the small, I don't really think it's actually small, but more of the macro versus micro, I would say, to do what you can, whether it's partnering with the church, partnering with community health organizations to provide a point of access, whether it's access to healthcare itself or just access to reasonable and informed information so that people can grow in their understanding of how to better care for themselves.
Thank you. Thank you so much, Dr. Sanchez Collins, and thank you for your time with us tonight. Dr. Parker, I turn it over to you. I know that you've been distracted by a call, but I turn that last question over to you. What do you say to the faith community as what's the role that they can play in alleviating these disparities?
Well, certainly most churches have a health ministry, and I would suggest that they engage with if they have parishioners that are in the healthcare field, that they have a council that helps in combining the religious aspect with the medical aspect in decision making. And the other thing I would say is that the church community should demand an audience with these major healthcare institutions. And that audience should be to address the healthcare concerns that exist in their communities with their parishioners. And there are a lot of ways. There's, I dare say, dollars out there because of social justice issues that have come about that are available to address some of these concerns. And now's the time to demand those things and to do it. And whether that be that physical infrastructure we talked about to put those access to healthcare in the communities, and don't forget to address those psychological aspects for training of healthcare professionals within the system, that they have a diversity, inclusion, and health equity council that is comprised of community leaders and church leaders for those major healthcare institutions.
Amen. Thank you so much. I think that the advice that you both have given us, given for this larger community tonight, has been invaluable. I think that you have opened up our eyes and you showed us again that we as people of faith have a role to play in this larger effort. I want to call on each and every faith community leader that's out there and say that we've got something to do. We've got conversations to have, as Dr. Parker just said. Talk to these healthcare providers in the community. As Dr. Sanchez Collins has said, we've got to begin to think more broadly about the way that we are engaging with these larger issues, making sure that we are taking our own personal responsibility in this larger effort. So this is our charge now as well, faith community. How do we stand up and how do we make sure that the people that we are serving are not just taken care of spiritually, but that their emotional, their physical, their other needs are also cared for? We can do so much if we work together in partnership in our community. Thank you all for giving us this advice tonight, for talking with us tonight. And brothers and sisters in the church, we've got work to do. Let's get busy. I want to invite you all to come back again and join us next month for our subsequent conversation. And I'll turn it over to Mike to invite you all to come back again. But know that the Center for Social Justice and Reconciliation, the Katie Geneva Cannon Center for Womenist Leadership are always here trying to help us better understand the way that race, the way that gender, the way that all of these things play a role in our lives, and to help us to be more broad, more understanding, and more inclusive in the work that we do in our congregations. God bless you all and have a great evening.
Thank you, Dr. Sadler, and thank you all for watching. Register now for a public conversation February 15th, exploring how faith and politicians impact voting rights, social justice, and religious freedom issues. Sponsored by our Center for Social Justice and Reconciliation and Center for Faith, Justice, and Reconciliation. Until then, enjoy the rest of your day.